Hello, I'm Ryan Rigby from Logan, Utah. Today we'll be talking about lateral ankle instability, specific the internal brace for the ATFL ligament. The way I've structured this talk is to briefly mention what the internal brace is. We'll talk about the surgical technique and some pearls, and then also I'd like to spend some time specifically talking about why we should be using it and how it's changed my practice over the last several years. And we'll wrap up with a couple case examples and some pearls. So for this technique, the nice thing is you really don't have to change the way you're approaching a lateral ankle stabilization currently. Do your standard dissection. I like to use a longitudinal incision. It gives me exposure to the perineal tendons if I need to. You can find the retinaculum, the anterior face of the fibula, and the lateral talus. From here, you can still do a modified Brostrom Gold and incorporate the retinaculum. It's nice to outline your anatomy before you start your repair. So I do prefer the technique of starting in the talus first. There's a couple of reasons for that. One of the benefits is it's easier to place that anchor into the talus by going inside the joint and then working your way out. I'll show you how that's to be performed, and then you end up with an anchor in the distal fibula. There is an animation on Arthrex website that does show step-by-step procedural techniques and pearls. For time's sake, we'll skip that today, but it's a nice resource for you to be aware of. One of the things I'd like to mention is placement of this anchor into the talus really should be placed inside the joint at first, just off the articular surface. There's a nice landing spot for this 4.75 millimeter anchor, but it's critical that we then pass the fiber tape outside the joint through the capsule. I still like to keep it under the retinaculum, but this is an extracapsular structure. So in the animation, you'll see the arrow actually coming in with the anchor inside the joint under what's left of the ligament. In the video, you'll see drilling 45 degrees back into the body of the talus. You drill here just above the sinus tarsi and you angle into the body of the talus. It's also very critical to make sure you tap with these anchors in the body of the talus. The 4.75 swivel lock is then inserted into the talus, and then from there, this video is showing how you pass the fiber tape through whatever's left of the ligament and through the capsule, making again this an extracapsular repair. So here's the suture being passed through the ligament, and my scrub tech is retracting the retinaculum out of the way. At this point, you still should do a modified Brostrom procedure. I do like to use a couple of anchors in the anterior fibula, and you tension your Brostrom as you would normally. Afterwards, then you would supplement or augment that repair by placing the internal brace over the top. As we place the internal brace, I feel it's critical to have the right amount of range of motion. I like to do 30 degrees of plantar flexion and have the internal brace placed fairly tight. However, it's critical that when you bring the ankle up to neutral dorsiflexion, you should easily be able to pass a hemostat underneath to make sure you haven't tightened the internal brace or over-constrained the joint. So this is not a replacement of the ligament. Think of this like a seatbelt. This is a check rein. This is the end range of motion to make sure that Brostrom repair does not stretch out or become over loose with time or during rehabilitation. So the anchor is inserted into the anterior face right at the origin of the ATFL fibers. And then again, I check this with a little hemostat at neutral degrees dorsiflexion to make sure that it's placed properly. And again, checking our range of motion and stability afterwards. The rehabilitation protocol has definitely changed. We'll talk about this in just a little bit. For me, currently, my protocol is to remain non-weight bearing for 2 or 3 days until the popliteal regional nerve block is completely worn off for the patient. And then they are allowed to weight bear as tolerated in an immobilization cam walker boot for the following 3 weeks. During that time, I allow the patient to remove the boot while they're sitting, but anytime they are walking, they must stay in the boot for immobilization. However, at 3 weeks, the patient is allowed to transition into regular shoes with a stabilizing ankle brace. And this is where I initiate formal physical therapy. Return to sports is somewhere between 8 to 12 weeks is what I typically will tell a patient. However, this is where we are seeing progress with the internal brace. Patients are pushing us and they are returning to sports on their own will much sooner. So why do we use the internal brace, or why should we use it? Well, we know that ligaments do better, soft tissue does better with early range of motion. It leads to better organization of the collagen, and ultimately that leads to a stronger repair in the end, which is that is a desirable thing for a Brostrom procedure. What do we know about repaired ligament strength? Well, we know if we take a perfect ATFL and we compare it mechanically to an ATFL that's had a Brostrom procedure that's been transected and repaired With suture and anchors, it's only about half as strong as a native ATFL. And then what happens if we place it through early range of motion, which again is a desirable thing? Well, there's been a study performed in Foot and Ankle International in 2008 where they found there was about 10% lengthening of the ATFL in this unprotected ligament, which is not desirable when we're trying to have long-term success and stability. So there's also a paucity of literature looking at long-term studies for the brostrum. Fortunately, we do have a 9-year follow-up from Mafuli in American Journal of Sports Medicine in 2013, and it was interesting to see that most athletes were not able to return back to their pre-injury level of activity. In fact, 42% did not return back. And so we have to ask ourselves, we think a brostrum procedure, we think these patients do really well, but really ultimately, how do they do long-term? And in my opinion, this is not good enough. 42% is too high of a number. So the real question is, how do we best protect the ATFL? Well, traditionally this required external global immobilization for lengthy periods of time, sometimes up to 6 to 8 weeks. Well, what happens to that ligament while we just sit there in a cast or in a boot? We know that this global immobilization leads to negative things in the ankle and with soft tissue, the muscles and the surrounding soft tissue structures, which is detrimental to athletes and regular patients. And we do know that early range of motion does have a lot of benefits. It improves the circulation, decreases the atrophy, it's better for the collagen. So what is the answer? The internal brace provides focal, customized protection for the ATFL. It prohibits excessive strain and stretch out during rehab and long-term and decreases the negative potential that comes from early range of motion. But yet the patient still has that proprioceptive feedback from the repaired brostrum procedure. So think of this as a seatbelt or a check rein in the end range of motion. Before stretch out occurs, the internal brace is there to protect the ligament. So does it really work? Well, there is a lot of literature that has been published and continues to be published, and you will see more in the future. But for me, there was a video that really caught my attention when I heard about the internal brace. This is courtesy of Chris Coetzee, a Minnesota Gopher football player, 7 weeks after a bilateral open brostrum with internal brace. And when I saw this video, this really caught my attention. There is power in this procedure, and I started doing the internal brace and adding it to my regular brostrum. Now, how does this stack up mechanically? When we compare an internal brace to a perfectly good ATFL, we find they're about equal in strength. It's at least as strong as an ATFL, and potentially even stronger. So how does this translate to my patients in my practice? I've seen that my post-op protocol has actually been cut in half. Traditionally, it was 3 weeks in a splint or a cast, non-weight bearing, followed by 3 further weeks of immobilization in a cam walker boot, finally transitioning into shoes and starting physical therapy with a brace at 6 weeks. Now my postoperative protocol has been cut in half with the added protection of the internal brace. As I mentioned, they do start weight bearing almost immediately with the protection of a cam walker boot for 3 weeks. Then they start a brace and physical therapy and rehab. So the first case example, this is my very first internal brace. This is a 62-year-old male. He was a paratrooper in Vietnam. Tells me my ankle gives out on me all the time, ever since NOMDOC. Well, this was his first procedure. He's just over 200 pounds, and he hasn't rolled his ankle for over 2 years. However, when I did use this for the first time, I didn't understand the concept, and I really placed the internal brace in under too much. It was too tight. I really pounded it in there, thinking that I was replacing the ligament. And unfortunately, at about 7 months post-op, he ended up having an impingement on the anterolateral aspect of his ankle. Fortunately, this resolved with a simple steroid injection. I have not had to remove that internal brace. It's stayed in, and he still has a nice, stable ankle. But I learned a great lesson that the internal brace can be placed too tight, and we need to be cognizant of this as we place the internal brace. This is a 17-year-old female where I performed an open brostrum procedure before the internal brace came out, and I did an open brostrum, and she later, 1 year, tripped off a curb and severely twisted her ankle. And the MRI showed a complete disruption of both the ATFL and the CFL. Now in this situation, this is where I would typically consider an allograft procedure, but this is a 17-year-old female. That was not a desirable thing, and I was able to use the internal brace and avoid the negative long-term rehab and potential stability down the road that an allograft often provides. And so I did an open brostrum with an internal brace, and she's doing really, really well. This is a 28-year-old basketball player, sprained his ankle all the time, even while wearing his brace. And I did an open brostrum with added the internal brace and he was back to playing basketball at 7 weeks, and he came in telling me, I'm playing ball and I'm not even wearing my brace, which was actually quite frustrating because this was early on and I was worried about him playing sports without the brace, but the patient refused to wear it and continued to do well all through his rehab and continued to play sports. I did not have any long-term problems. And that's really what you'll find as these patients start to push you, and you'll start to realize how powerful adding this augmentation really is. This is a volleyball player 6 weeks after an internal brace. You can see, for one thing, the lack of swelling, but not only that, look at the proprioception. Look at the confidence that she has in this ankle to be able to hop on both feet up onto the stool. A friend of mine was a Division I football player, had a traditional brostrum 4 years ago, and he tells me he did absolutely fantastic for 3 years. But now the ankle has loosened, it's unstable again, and he's only 28. We haven't done the procedure yet, but I'm confident that this young individual has a really good solution that will provide much longer-term outcome than just simply 3 years. So in summary, some key take-home points. It's critical that we remember this is not a ligament replacement procedure. Instead, this is a ligament augmentation procedure. It protects the repair. It doesn't substitute for the repair. Think of it as that check rein or that seat belt concept. This should be at maximum tension at about 30 degrees plantar flexion, and we do need to avoid over-tightening the internal brace. And I do pose the question, why not? Why not take a few added minutes to place this in to make sure that our patients do well, not only through early rehab, but also long-term, as we do need to question our long-term success with the brostrum procedure. So to circle back to my original question, why should we change a good thing? Well, in reality, we're not. We're simply taking a good thing and we're making it even better.